for surgery. The second group, high-risk women attending IVF, for example, give DRT programs where the intense surveillance is needed. This is the group you are most likely to pick up unruptured ectopics, because when somebody goes through IVF, if she misses the period by 4 days, everybody is anxious. The IVF specialist is anxious, the patient is anxious that they want to see a pregnancy somehow there. So they'll go and do many scans. I have seen patients undergoing 14 scans before 11 weeks. 14 scans before 11 weeks. Then every second day, third day, review scan, because they are looking for that gestation sign. Third group is patients with subacute presentation. This group is the largest group because, as we said, low risk patients, no need to do early pregnancy scan unless there is a symptom. And the symptom is pain abdomen. When they come with pain abdomen and a positive pregnancy test, they will be done, and you have a high index of suspicion. Any early pregnancy patient with pain abdomen is ectopic until proved otherwise. You have to think ectopic. And just to give you some numbers, if the gestational sac is 1.5 millimeters, embryo is 0.5, the mean beta HCG will be around 28 milliliter per ml. If the menstrual week is 7 weeks, the gestational sac is 40 to 100 millimeters, then the HCG can go up to 50,000. You can see the rapid increase in the HCG between 4, 5, 6 and 7 weeks. The discriminatory zone for transvaginal ultrasound is between 800 to 1000 milli-international units per ml. Transabdominal ultrasound between 1800 to 3600 milli-international units per ml. Which means if I have a beta HCG of 200, I do a scan and I don't find a gestational sac either inside the uterus or outside the uterus, I am nowhere. I cannot prove that the patient has ectopic, I cannot prove the patient has inside the gestation. So we call this as pregnancy of unknown location. Because beta HCG is 200, there is a suspicion of pregnancy. So we call it as pregnancy of unknown location, and that's a standard terminology used nowadays, till you identify where the location is. Okay, so this is just to show you that there is a ectopic here. Now, many people talk about color Doppler and ectopic. Remember, the primary diagnosis of ectopic is by D-mode ultrasound. It's not color Doppler. Okay. Now, you can, when you switch on color Doppler, then you can see what they call as the ring of fire, or some any terminology you want to give it to, saying that there is a gestation. The corpus luteum cyst will also show you the ring of fire. So you might actually get misled. So important thing is, if you see a sac, look for a fetal pole inside. If there is no fetal pole and pregnancy test is positive, there is an adnexal sac or adnexal ring, maybe with or without color, you don't bother. There is no intrauterine sac, you have to consider that as ectopic. You have to think that I say, I will treat it as an ectopic pregnancy. Now when I switch on color and you have lots of color there, okay, now I think there's an adnexal ring with the, in some cases you might mistake a corpus luteum cyst, so you have to be careful about it. Now when there is an abortion, tubal abortion, then things are much different, because you see fluid in the pouch of Douglas. When you see fluid in the pouch of Douglas, ask yourself only one question: is there internal echoes in the fluid or no? If there are internal echoes in the fluid, then it's hemorrhage. That hemorrhage might have come from a ruptured ectopic, or it could have come from a ruptured corpus luteum cyst, but still it is hemorrhage. But internal echoes is, so turbid fluid is very important. Right? Then you can have unruptured ectopic pregnancy, or you can say a chronic ectopic with a tube ovarian mass. So any type of things can happen. Here you can see an interstitial pregnancy, and here you can see there are 4 sacs. There are 4 sacs. 1, 2, 3. The 4th one is interstitial. So she had an IVF pregnancy, 3 intrauterine and 1 interstitial. And imagine what the patient must have gone through. So we actually selectively reduced this by giving it potassium chloride. Subsequently, she ruptured this. The rupture was repaired. Subsequently, she came for reduction of this triplets to twins. We reduced the twins and she delivered twins at the end of the day. So people can take a lot of things, I think. Now here's an inevitable abortion where the sac is almost in the, she's having pain, bleeding, and the sac is already in the cervical canal. And this is something where the sac probably has just expelled, and the difficulty is when an abortion has taken place and she is, or you have done a DNC,
closed.
she still continues to bleed. That time, people say do a scan to find out whether products of consumption are still there. And it can be very difficult to differentiate between products of consumption and blood clots. Right? Sometimes if you put color Doppler, if you see color inside, there are still viable products are there, then you can see. But otherwise, you can have difficulty in differentiating between products of consumption and so on. Here is a hemorrhagic cyst, which will account for the pain. And here, this patient had a torsion of the ovary. You can see a very enlarged ovary, a hyperstimulated ovary has got a higher risk of torsion anyway. Right. So you should look at pitfalls. Look at this picture here. It looks like two gestational sacs. But within a few seconds, we find the whole thing became a single gestational sac. This is a large myometal contraction, which actually constricts in the middle, and like a hourglass constriction makes appearance of a two gestational sac. So you have to be quite careful about it. Here also, you can see a subendometrial cyst. This is actually a subendometrial cyst, which is posing as a gestational sac. Sometimes you can have pseudo-gestational sac. Then fluid in the uterine cavity can be mistaken for a gestational sac. Right. So we find that early pregnancy, that before 10 weeks, we help in assessing viability, location, and it excludes causes of pain in early pregnancy. We are not going to diagnose any anomaly before 10 weeks. Major issue. Not. Secondly, multiple pregnancy, be extremely careful about talking about the number, because if you see two distinct fetuses, two distinct cardiac activities, two distinct sacs, yes, you can say that. But if you're in doubt, wait for some more. That's all we can say at this point. Okay, from here what we'll do is we will go on to the demonstration of the early pregnancy scan. Okay, is somebody there for it? Dr. Vidya is with us today, and she is a fetal medicine specialist. She is from Trivandrum, and she was trained in Australia, and she done an MRCOG. So we requested her to help us with the program today. So she will first case she will demonstrate from there, and I'll explain to you from here, and then we'll take her turns. Any questions? Please feel free to ask as many questions as you want. No restrictions.
Because you're talking about this first trimester scan, and last month we had a problem. It's a scar pregnancy. So how are we to confirm the diagnosis of scar pregnancy in the first trimester, in the previous section?
Well, in a patient with previous section, if we have any patient with previous section today, I'll show you how the scar appears. In a non-pregnant state, it is very easy to see the scar. If a patient comes to me for a pelvic scan with a previous cesarean section, I can easily tell you that she's had a cesarean, because we'll be able to see that point of the scar. As I said, any gestational sac which is implanted low in a patient with a previous cesarean section, I will view that patient with a high index of suspicion. Either, okay, she may abort, or the sac is adherent to the scar. Ultimately, the placenta will start invading the umbilical. So, looking at the location of the gestational sac is the key. If the sac is located at the fundus within a scar, highly unlikely that's going to cause trouble for us.
Anyway, the doctor or anything confirm that it is not a sac near the scar, or it is exactly a scar pregnancy itself.
Okay, this can be done only by high resolution ultrasound, transvaginal ultrasound. We need to zoom the area a little bit to know where exactly the scar is located. Color Doppler is really not going to help. It's going to actually define the cavity line and the relationship of the sac to the cavity line.